And now I want to take a few minutes to introduce our keynote speaker. And Brett King was kind enough to accept this invitation. Brett is an associate professor of dermatology at Yale University School of Medicine. He specializes in inflammatory and autoimmune skin diseases. He has pioneered the use of JAK inhibitors in vitiligo. As many of you know, the initial Tophasidinib article that he wrote became a game changer for many of us, and it very much verified a lot of the work that John Harris and Julian Seneschal and others were talking about. He's done work with alopecia areata, vitiligo, atopic dermatitis. He's an incredible lecturer. He's received his MA from the University of California at Santa Cruz, his PhD from Stanford University, and his MD from Yale University. He also did a medical internship at Mass General. He has attended some of the best institutions in medicine, organized medicine in the United States. But more than anything else, he's this wonderful, kind, charismatic leader who's inclusive. The few encounters I've had with him have always left me with an impression of somebody who deeply cares about the science, but more importantly, he knows he's a servant to the patients that we are serving as a physician community. And so I wanted to welcome Brett King. The only limitation he has in his CV is that he never spent time in Detroit, but I hope to change that in the next few years. Brett, welcome. Brett, if you could unmute, please.
There we go. I was just saying those were probably the kindest words that have ever been spoken about me. And so I'm hoping that this is recorded so I can go back and listen to those. But thank you very much for the opportunity to be here. I'm very appreciative. And let me pull up my slides. Can everybody hear me?
Yep.
Perfect. Okay. So I'm going to I'm hoping that this talk stirs up a little bit of controversy or discussion. I again, I very much appreciate the opportunity to be here, but I'm not nearly as deeply embedded in vitiligo as others of you are, and so this is really kind of my view of vitiligo and its treatment from, in a sense, I think, kind of from the outside. These are the learning objectives. These are my disclosures. Really, the only one I want to make special note of is the top bullet, and that is that I hold a patent for treating vitiligo with JAK inhibitors in combination with phototherapy. And these are my patients. And these are the people who, like for so many of you, right? These are the people for whom I wake up and go to work every day, and try to kind of solve their problem for them or with them. And I'm very much a therapeutics person. And so let's just dive right in to the vitiligo treatment algorithm. And I'm not so much going to spend time on the algorithm, but the elements of the algorithm. The only FDA-approved treatment for vitiligo is a depigmenting agent, and it's relatively uncommon that anybody's goal is to lose more pigment, right? What we want and what our patients want most of all is to have normalcy restored and their pigment returned. And the things that we have in our tool chest really are topical corticosteroids, topical calcineurin inhibitors, narrowband ultraviolet B phototherapy, and then we also employ oral corticosteroids sometimes. And then in some cases, we'll also use surgical treatment. And there's a role for all of these things, but I think overall, we want a richer, deeper tool chest. We want more reliably effective therapy. We want therapy that is both more reliable, but also more quick to act. So shown here is, I as much as possible, I think that we should always turn to science to understand therapeutics. I think it's, and I think everybody would agree, right? It's better to start here than to just throw medicines at a disease or at patients in the hopes of discovering something. And this is a cartoon pulled from a paper that we wrote, or work that we did with John Harris, which fundamentally, as Iltafat pointed out, is based on John's work in the mouse model that he has for vitiligo. And in this concept of the disease, keratinocytes secrete CXCL9 and CXCL10 that activate T cells. T cells in turn secrete interferon gamma, which have a receptor on keratinocytes. And you can imagine this cyclical loop that leads to inflammation and ultimately keratinocyte or melanocyte destruction and pigment loss. And so in my mind, the question emerges, is halting T cell destruction of melanocytes enough to achieve repigmentation in vitiligo? So that is, if we eliminate the T cells, then the process must, at least in this cartoon, the process stops and then pigment is restored. That would seem to be true. I'm going to spend the rest of my talk trying to answer that question. So this was the first patient treated with Tophasidinib for vitiligo. This is the patient when I met her at baseline. She had very rapidly progressive disease. She had been progressing over the last 2 years, kind of unabated. I offered that Tophasidinib might be an interesting way to address her disease, which was generalized. And indeed, over 5 months of Tophasidinib monotherapy, she repigmented her face. And as you can see here, she also repigmented, well, her arms aren't showed, but she repigmented her arms in the sun-exposed areas, and surprisingly also, quite spectacularly, the backs of her hands as well. Very interestingly, the vitiligo involving her other body sites. Remember, she had generalized, so she had vitiligo involving her head, her torso, her arms, and her legs. Really, the vitiligo that she had in parts other than her face and her arms and backs of her hands did not respond. Subsequently to that, but not long after, John Harris published this report of a patient who was being treated in an alopecia areata clinical trial with oral Ruxolidinib, so at the time the other JAK inhibitor in the world, and noticed over the course of that trial, 20 weeks to be exact, had significant repigmentation of his face, which was lost after stopping the medicine. But nevertheless, we now had 2 JAK inhibitors, 2 different patients responding to just an oral medication. Subsequently, David Rosmarin at Tufts did an open label clinical trial using topical Ruxolidinib. So remember, John's patient was treated with oral Ruxolidinib. Now this is a clinical trial with topical Ruxolidinib. And similar to the last 2 observations, patients with facial involvement enjoyed significant repigmentation of their faces, or of the vitiligo involvement of their faces, but shown in the figure on the right, they did not enjoy that much or achieve very significant repigmentation of their total body vitiligo. So along the way, I was treating numerous patients with oral Tophasidinib, which an important call out, I think it's clear, but none of these medicines are FDA approved for the treatment of vitiligo. But nevertheless, I was treating numerous patients off label with Tophasidinib, and overall, the results were not nearly as stunning as the index patient, who, by the way, is patient number 1 here. But if you notice that over the first 10 patients treated, the first 5 achieved some degree of repigmentation, a couple of whom experienced significant repigmentation. And it started to become clear to me, putting together the different pieces, that this was a function of light exposure. And so going back to the index patient, she had repigmented over 5 months. She stopped the medicine. She went back to where she started. She came back to me at the start, or at the end of winter, at the start of spring, and said, I've lost my pigment. I want to try this again. And so, realizing that there was an opportunity here to try to understand this a little bit more, or a little bit better, I asked her to go see John Harris for blister fluid studies to see if we could understand why some of her body sites were repigmenting, but not others. Of course, we were assuming that she was going to achieve repigmentation a second time around. It turns out she did, but because we had the experience with her the first time, we knew where she was going to, we thought we knew where she was going to repigment. We knew where she did not repigment the first go around. And so what John did and the folks in his lab did was they did suction blister and fluid analysis of responsive areas and unresponsive areas, and then, quote, uninvolved skin. And this is what John found. So on the far left, you see the Tcell response to treatment, and you see that so there are three different lines here. There's R for responsive skin. So this is skin that repigmented over the course of treatment. There's NR, or non-responsive skin, ultimately photoprotected skin. And then there's NL, non-lesional skin. What you see is that the CD8 T cells decrease in numbers dramatically with Tophasidinib, regardless of whether it's skin that repigments or not. Then looking at CXCL9 and CXCL10, we see a similar trend. And so regardless of whether the skin repigmented, you see a dramatic drop in CXCL9 and CXCL10 in those two areas of skin. Again, what separates or distinguishes these areas fundamentally, all of the skin is being exposed to Tophasidinib, but only the responsive areas, only the repigmenting areas of skin are seeing sunlight. And so that, to me, I mean, this was a real kind of breakthrough for me anyways. And going back to the mechanism of disease that we just talked about, and again, this question, is halting T cell destruction of melanocytes enough? Well, I don't think so, because with Tophasidinib, John's experiment showed that indeed we were blocking this process. We were muting this interaction between keratinocytes and T cells, but we weren't getting repigmentation in sun unexposed areas. And so it really seemed to me to suggest that this is a two-step process. You have to both shut down the inflammatory destruction of melanocytes, but then the melanocytes themselves don't just come back to life, or they're not constitutively active, or however you think about that, but rather you need light to stimulate melanogenesis. So with that in mind, I then said to everybody who came to see me, and since that time, I've said, we can only treat you with these medicines as long as you agree to do both phototherapy and take the medicine. Either rub the medicine on your skin, a compounded form, or take it by mouth. So this was the first person to do that. This was a woman who had vitiligo for 14 years, progressing over that period of time. And she started Tophasidinib concurrent with narrowband ultraviolet B. Note the dose here. I didn't shoot for high dose because I wanted to see if a relatively low dose would suffice. And indeed, twice weekly, relatively low dose narrowband ultraviolet B plus Tophasidinib achieved greater than 90% repigmentation in 3 months, which was sort of an astonishing result. And then you can see at 6 months, there's nearly 100% repigmentation, of course, lips accepted. These are other body sites. So showing here her neck and her chest. Again, 3 months, not quite as dramatic as the face, but quite dramatic. 12 weeks to get this level of repigmentation is really kind of amazing. And then 6 months, near complete. Her arms and her legs were complete. In a second patient treated in the same way, this was a man in his 50s who I had originally met several years before, who had come to see me having done phototherapy and having done eczema, having done all the topicals without success, was very concerned about his face. And so we undertook monobenzyl ether of hydroquinone treatment of his face with near complete depigmentation that was stable over 4 years, when he came to see me to ask if we could try this. I said, it's a long shot. The literature says that there's a good chance that you don't even have sites anymore in your face. So I can't predict how this is going to go. He said it was worth trying. We did. And slower than in the woman shown here, but an F-VASI 50 in 3 months and F-VASI 75 in 6 months. So again, this is not an observation unique to my experience. Indeed, these were patients also seen. In fact, these were patients in the second part of the topical Ruxolidinib open label trial that David Rosmarin did. And in this part of this extension, if you will, of that trial, they offered ultraviolet or narrowband ultraviolet B phototherapy. Not most of the patients did not go down this path, but a few did. In particular, the bullets here, topical Ruxolidinib monotherapy had little effect in both of the patients shown here. And both patients had failed prior phototherapy. So you look at them at baseline, you look at week 20 with, so 20 weeks of topical Ruxolidinib only, you see very little change, very little repigmentation. Now you add narrowband ultraviolet B, and over the next 30 weeks with phototherapy and topical Ruxolidinib, you see, in some cases, dramatic repigmentation. Again, kind of adding to this this hypothesis or this concept that you really need both. This is another patient of David Rosmarin's that he had treated with topical Ruxolidinib, I think probably also from the trial, but again, you see this is somebody who wears a hat all the time, and you can see in panel C that he was experiencing quite a bit of repigmentation of his face, except for the sun-protected forehead, which is nicely depicted in panel B. David says, take off your hat. Now, you can't wear your hat. And what you see over some period of time subsequent to that is repigmentation occurring on the forehead. These now, this was a study of Amit Pandya's. So now here he takes 11 patients, treats them with 2% Tophasidinib and narrowband ultraviolet B 3 times a week for 3 to 4 months. These patients, important here, patients had previously failed more than 3 months of treatment with topical corticosteroids or topical calcineurin inhibitors, in addition to narrowband ultraviolet B or sunlight. Over 3 to 4 months, he gets a quite dramatic change in their facial vitiligo, which is where they're applying the topical Tophasidinib. Now here, this is a case report that my wife, she's a pediatric dermatologist, just recently published. A 4-year-old with segmental vitiligo had used alclometazone for 6 weeks, which is not the longest trial, of course, and we'd typically call that inadequate, but was doing, there was no movement in the pigment over that period of time, at least no visual change in the pigment over that period of time. And so she started or treated the patient with topical Tophasidinib, 2% cream, a little handheld, $300 handheld narrowband ultraviolet B wand at home 3 times a week, and dramatic at 3 months, 6 months complete. So what about other treatments besides JAK inhibitors? So topical calcineurin inhibitors. There was a really great meta-analysis recently in JAMA Dermatology a little over a year ago, and it showed, just look at the left-hand part of the screen and then the right-hand part of the screen, and you can see that the bar graph on the right shows much higher treatment response, and that's topical calcineurin inhibitors plus phototherapy. I mean, dramatically higher levels of repigmentation. Again, this is this is a systematic review, but the point is the difference is so dramatic, it's really hard to argue that there's not something there. So combination is better than monotherapy. And then lastly, a study of afamelanotide, an MSH analog, and narrowband ultraviolet B. And once again, you see that looking at the figures on the right, afamelanotide plus narrowband ultraviolet B is better than narrowband ultraviolet B monotherapy. So a slightly different view of the same question, but I think an important piece of data. So to wrap up, ultraviolet light in combination with other therapies for vitiligo. Is it synergistic or is light necessary? This is a patient who I literally just saw a couple of months ago for his 12-week follow-up. I met him late last year. Those images are on the left. As you can see, he had, probably 70% of his torso depigmented or affected by vitiligo. This process had been in evolution for years. He had tried phototherapy with very little success. And so just the extent alone, in my mind, makes him an oral therapy candidate. He got into narrowband, got into the light booth before he got his hands on Xeljanz. So at the time of the second set of pictures, those are exactly 12 weeks after the initial photos, 10 weeks of Tophasidinib, 5 milligrams BID. 99% repigmented. Dramatic. Too dramatic to argue about. There's something here. And so getting back to that model, repigmentation in vitiligo using fill in the blank may require concomitant light exposure. I think that this is broadly true. I think that repigmenting vitiligo is a two-step process. You have to shut down the inflammatory destruction of melanocytes. But usually, I'm not saying always, but usually that's not going to be enough, because if you don't stimulate melanogenesis, you're not going to get to the ultimate goal of repigmentation. So in summary, the observation of enhancement of repigmentation when ultraviolet light is combined with other therapies is important. I think that we can't ignore it. I really believe that all of this points to the fact that, or the proposition that effective treatment of vitiligo may be a two-step process. Ultraviolet light in combination with other therapies seems to be synergistic, and I might say it's necessary for reversal of disease. UVL, this is kind of the exciting part of this, right? Because we all understand, everybody who uses narrowband UVB understands the pain and the hassle, the difficulty for patients. But it's not a perpetual proposition. It's time limited. We just need to get the pigment back with light, and then hopefully we have some other therapy that effectively keeps the process from reoccurring. Of course, the results, this is just a lot of conjecture based on limited data. The results of large clinical trials will be critically important, obviously, for clarifying the potential role of UVL. And that's it. Thank you all very much for your attention.
Well, thank you so much, Brett and Dr. King. Thank you for this wonderful presentation. Brett, can you see some of the questions in the chat box in the Q&A? If not, I can kind of go over them. How about side effects using Ruxolidinib oral and topical?
So So, I have to say that oral JAK inhibitors in my patients have not been a bad experience for anybody. I must have probably at this moment in time somewhere around 250 to 300 patients taking mostly Tophasidinib, but a handful Ruxolidinib or baricitinib or Apatocidinib. And if I've had 5 patients stop for a side effect, I would be surprised. And even if I'm off by a factor of 2, we're still talking about a really small percentage of people. So the whole concern about labs, there's the truth is there's not a whole lot of concern even with laboratory abnormalities so far. Obviously, we're I think the important data there is going to be when JAK inhibitors are trialed cleanly in dermatology and in dermatology patients, not right now, in a sense, we're kind of borrowing all of our safety data from rheumatology and gastroenterology and hematology and oncology, and really, right, we want data for these agents in patients with vitiligo, with alopecia areata, with atopic dermatitis, and hopefully that data is coming soon.
Great. I wanted to add, welcome our colleagues from Turkey, and Dr. Sajkin from Istanbul asked regarding repigmentation, is there a difference between the calcineurin inhibitors and the JAK inhibitors? Do they both have the requirement? Do you think the JAKs have a greater requirement than the calcineurin inhibitors?
I'll tell you, that last, it was part of the reason I put up that last set of images. I mean, there's something awfully spectacular about what happened in that man, just like the woman that I showed. And I don't think, honestly, I would be surprised if that, and this is pure conjecture, but I would be surprised if that could be achieved with calcineurin inhibitors. I do believe, again, it goes, for me, I hope that, with every passing year, but for sure with every passing decade, I hope that we're using, fewer and fewer super non-specific agents. It's like, right, as people like John are advancing the science, I'm really hoping that science leads to more targeted treatments. And people love to say, oh, but JAK inhibitors aren't targeted. Oh, well, they're certainly a lot more targeted than calcineurin inhibitors. They're not a monoclonal antibody, but they're targeted. And right, one would hypothesize based on that model of disease that targeting interferon gamma is going to be much better than just suppressing T cells. And so I think that we're going to learn that this mechanism of treatment or pathway is much more efficacious than other modalities.
And then just 2 more questions, Brett. We got 4 minutes left, so I'm going to combine 2 of the questions.
Sure.
Do you think that there's, it's well known that oxidative stress is a factor within vitiligo described in basic science groups, yep, as also clinically. Do you think there's a fine line between inducing repigmentation and inducing depigmentation with phototherapy or light exposure?
Oh boy. I'm going to give that question back to you.
Yeah.
As the person who knows far more about that process than I do, I would love to hear your answer to that question. What do you think?
I think that anytime you induce a phototoxic response, you're at risk. And about 10 to 30% of patients with vitiligo are photosensitive or at least non-photoadapters. So I think probing your patient, assessing how their sensitivity is important. And then in that population who's not sensitive, you proceed. If they're very sensitive, I think you have to walk a very careful line. And if they're ANA positive, you can still do it, but your dose is much lower. Your dose increments are lower. But again, we're going to have some really good talks on that. So, good pivot. You should run for office. Brett, last question. The patients in the studies, how long did it take them to depigment after you stopped the Tophasidinib? And what's your sense of the level of stability of these patients?
Yeah, it's a great question. I will tell you. So the index patient, she stopped taking it in October, if I recall exactly. She stopped taking it in late October and returned in spring. So it was, 5 months at least for her to manifest a significant amount of depigmentation. And I would say that's approximately true for the other people who, it's like they do therapy, they're doing well, a bump happens with insurance changes, whatever. And then it's a months long, let's say kind of on average 4 to 6 month long process before the depigmentation is apparent again. So by no means, right, should we be thinking of this as a something that is durably altering the disease process.
Okay. Well, thank you so much for taking the time to come join us today. It's been enlightening, and excuse the pun, but it really has been. And again, thank you so much for your leadership. You're doing some incredible work that's coming out. I can't wait for our community to see the work that you're producing. And some of us are working on different projects, but it's exciting.
Well,
and to have a PhD scientist in vitiligo, it's great. Thank you, Brett.